Hello, everyone. Thanks for coming to the today's lecture. So I will be talking about morphology, which is a universal language for dermatologists. I have no conflict of interest. And the learning objective for today, there are 5 of them. So we're going to talk about some tips for taking a derm history and then some tools we use in dermatology examinations. And then we're going to talk about, going to review primary and secondary lesions in morphology. And then we also going to talk about like what are other components of describing the morphology besides the primary and secondary lesions. And then we're going to use 4 cases to practice morphology. And I will be showing pictures of patients with a spectrum of skin of color to show how rash can be different in patients with skin of color. So the first one is everyone knows, hopefully everyone kind of like have some idea, like know how to take a history. However, when it comes to dermatologies, there's some tips you need to consider when take a dermatology history. So in medicine, like for non-derm specialties, we're being taught to like start with the history taking, like ask questions, like focus question, ask about medical background, and then you move on to examine the patient, listen to the heart, listen to the lungs, for examples, and then followed by investigation, for example, like blood work, urine tests, imaging studies. This is in most specialty, this is kind of the trend. However, in dermatologies, sometimes it is very beneficial. You kind of like start looking at the rash, and then you move on to take the history, and then you can do investigation, because the morphology of the rash can actually pointing you towards particular group of differential, and then you can ask question based on the differential. So if any medical student, when you're doing like a rotation, when you're doing elective, and always kind of like pick the rash first, and then start asking questions. That can save you lots of time when you, for example, on like a busy outpatient dermatology rotation. So in terms of like the history for all medical specialty, this is what we go by, kind of identification, chief complaint, blah, blah, blah. However, for dermatology, there's a few like high yield important point you need to consider when you're taking those histories. So the first one is in identification, it is crucial to consider ethnicity of the patient, because that can change how the rash appears in patients with different skin of color. And then in the HPI, and then you want to use the patient's own words when presenting to the staff. You want to see the patient comes in complaining of like flaky like spots on the chest, instead of like saying patient presented with like flaky like papules, because patient will not use those words papules. It's better to describe in patient's own words when you're presenting to the staff. And in terms of allergies, you want to ask about like what kind of reactions. This is particularly important for like dermatology, because there's many a rash can be caused by different kind of medications. You want to clarify if it's true allergies or it's actually intolerance. And in terms of medication, most people will forget about like topical and ophthalmic medications. They do not consider those as medication. You want to specific ask them, do you have any prescription medication you put on your skin, put into your eyes? Because oral mucosa and like eye mucosa are part of the complete skin examination. And in terms of social history, you want to particularly ask about drug benefit, because many of the medications can be expensive. You want to make sure the patient has sufficient drug coverage. So when it comes to like more specific dermatologic history, I love mnemonics. Like my mnemonics for you is 3 T's. You want to ask, number 1, ask about the timelines. For example, when does the rash start? Where the rash start? And then how did the rash evolve over time? And then how has it spread? Is it spread from head to toe, trunk to the peripherals? Or because that make a difference is, for example, like particular like drug, or particular viral exanthem can have different particular pattern of like spreading. And the second one is trouble. And you want to ask the patient, does it itch, burn, or hurt? And anything make it better, particularly asking about heat, cold, exercise, and any other reasons. And ask about the patient, what has been tried before, and then how did they try the medication. Because as a specialist, dermatology usually see patient already got some treatment from the family physician. You want to ask about like more about the details, like how are they complying with the medication? Are they applying the medication correctly? And then another one is psychological impact, because many of the conditions can have like significant like impact on the patient's mental health, including like depression, anxieties. So you want to make sure you ask about those troubles as well. In terms of triggers, you want to ask about what is in contact with the skin. You can think of like indirect and then direct contact. Indirect contact, most common with sunlight, and with direct contact, it is mostly kind of anything in contact with the skin, including like new creams, makeups, new clothes, shoes, watches, accessories, and then like animals. And then lastly, ask about travel history, any like bug bite and tick bites, because those can cause either like kind of like particular kind of dermatitis or can cause any kind of particular rash associated with like those like bug bites and tick bites. And then in terms of like past medical history, we want to specifically ask about skin cancers, and then the type of skin cancers, and then how was it treated. And then if the patient is not sure about what kind of skin cancer they have, you can ask them like, was it treated with like liquid nitrogen? Did you get medication? Did you get like big surgeries? Did you get any radiations? This can help you differentiate what kind of cancer the patient had before. And if the patient told you to have melanoma, you want to ask them like how deep the melanoma was, because that's the most important single prognostic factor. And you want to ask about like, did the surgeon have your lymph node removed? That's also indicate more invasive melanoma. And then you also want to ask about like atopic triad, including atopic dermatitis, asthma, and then allergic rhinitis. I think it's important to know those three. More importantly, know atopic dermatitis comes first, and then followed by asthma, and then followed by hay fever. If a younger patient like only have atopic dermatitis, does not have asthma or hay fever, doesn't mean they don't have the triad. It only means they may have the triad later on when they become older. The other ones asking about like any blistering sunburns, any like tanning bed use, because those are the big risk factors for having any kind of skin cancers. And in terms of medication, I mentioned before, like asked about like timelines, because any kind of like drug-induced rash, the timeline is the most important factors. For example, like which is like the start of the rash and then to the start of the medication, because this can help you generate differential and help you point towards what kind of drug eruption does the patient have. And in terms of family history, you want to ask about skin cancer in the family, particularly melanoma, and then also ask about if anyone in the family have any shared skin conditions, because one branch of dermatology is called genodermatology, because many of the skin conditions can have genetic conditions associated with it. So you want to ask about those things. And in terms of social history, you want to ask about occupations, particularly sun exposures, and also any contact allergens at work. So that was the kind of like the history part. So just some some tips for you guys. When every time you see a rash, make sure consider those questions you can ask the patient. And then we're gonna move on to the second part, talk about different tools we use in dermatology to kind of like help us generate differential, make the diagnosis. So the first one I highly recommend when you're on elective is to bring a ruler with you, okay? And then so because accurately record the size of the lesion is very important. And then particularly when it comes to skin cancers. And then in terms of how you measure the size, you want to measure the longest axis first, and then measure the one in perpendicular axis, and then record as 6 times 4 millimeter, for example. The 6 will be the longest axis, and then 4 will be the perpendicular axis. And also bring a pen light, or even there should be some like pen lights, or should be some lights like in the exam room usually. The reason you want to differentiate any atrophy or like any like fine wrinkling of the skin, that can be very subtle if the light is not sufficient enough, and can also help you differentiate like subtle, like flat versus raised lesions, and then can also help you decide where the lesion is. Is it like a pustule versus or like papules, or it's like or like a vesicles? Can help you differentiate what's inside the lesions using the pen light. And then lastly, can also help you look into the mouth, because a complete skin examination, including examining of the whole body and also examine the hair, nails, and also the oral mucosa. So you want to look into the mouth to see if the patient have any like lesions in the mouth. The next one is dermatoscope, like dermatoscope, which is a fancy camera, basically magnifying the lesions for to look for fine details. When you're on elective on rotations, you can ask your staff or like resident to borrow their like dermatoscope for any kind of pigmented lesions, especially for like melanoma, because they can look very different under the dermatoscope. And then the resident or even like the attending physicians can show you like how to differentiate those features, and then like on the dermatoscope. And the next one is the wood lamp, and then which look like this in the picture. It's like a plug-in device, and then they basically like shine lights, UV lights at a peak wavelength of 365. That's a common pimping question. They're gonna ask you like every time they show a wood lamp, like what's the wavelength? The answer is 365. And then because the reason being like the skin has like can have like specific fluorescence appearance under the like wood lamp, and they're very helpful in terms of differentiating two kinds of conditions. The first one is any bacterial fungal infection, and the second one is pigmented disorders. Those are the high yield ones you can use the wood lamp for. Just to give you examples, for example, in the picture on the left side, you can see the skin looks fairly normal. However, under the wood lamp, you can see there are some like well demarcated like depigmentation of the skin. This is actually a diagnosis of vitiligo, which is a very common depigmentation disorder caused by autoimmune destructions of the melanocytes, which is the cells in the body in the skin that produce melanin. And an important part when you're on elective seeing patient with vitiligo, you need to ask about like other autoimmune conditions, for example, like type 1 diabetes, Hashimoto thyroiditis, or those kind of like autoimmune conditions. And you also want to address about like the social, like psychosocial component, because in many cultures, particular patient with like darker skin, and then there's a significant stigma associated with vitiligo. And then lastly, I want to ask about any like depression or anxiety symptoms, because there are many like systematic reviews or any like articles suggest strong association with of depression and anxiety with vitiligo. And then the picture on the right side is Winnie Harlow. She's a Canadian model who's a advocate for vitiligo. You can see she does have significant depigmentation on the skin, and then marked by the sharp demarcation, and then completely whitening, which is depigmentation of the skin color. And then the last one is endoscopy, which is basically a glass slide. It is very helpful in differentiating erythema versus vascular lesions. Vascular lesion, I mean petechiae. And how you do it is you want to have the slides and press the slides against the skin and observe under the slide to see if it's to see how does it look like under the skin. If it's like, does the rash gone or the rash stays? Because this is really helpful to differentiate where the bleeding is. And then if the rash is gone, as you can see in the middle picture, and then that means the erythema is most likely due to red blood cells, increased red blood cells within the blood vessels. And then if the rash stays, as you can see on the right side of the picture, that means the blood cells has extravasated into the skin. That means the red blood cells is outside the blood vessels, and then this is suggestive of petechiae. And then by differentiating erythema versus petechiae or vascular can really help you generate a more like refined differential diagnosis. So, and then we're gonna move on to talk about like overview of like the primary and secondary lesions in morphology. Hopefully you guys already have your dermatology lectures, so you have some basic knowledge about it. We're gonna quickly run through some high yield, like important to know tips for those morphologies. So what is morphology? It is basically a series of medical terms used to describe the appearance and texture of the skin findings. And then you want to ask, like, why do you want to do morphology? The reason being, like, number one, documentation. You want to document the detailed findings in the medical chart. And then second, most importantly, it actually helps you generate a list of differential diagnoses based on the morphology. That is how dermatology stands out among other specialties. Why it's so unique? Because dermatologists can actually generate differential based on the appearance of the rash. And then lastly is to communicate. For example, if you're sending a referral letter to a specialist, you want to describe the rash fairly accurately, so the referral physician can triage the rash, can triage the referrals appropriately, and then like have like the most optimal treatment for the patient. So morphology is actually fairly intuitive. And I want you to kind of like look at this picture and then in your mind, trying to describe this object. Okay, use many words as possible and then be as detailed as possible. And then we can probably come up with something like this, like on the round table, which is location, there's one, which is location, red, which is color, circular, which is shape, shiny, which is texture, object with a small imagination on top, and it measures about 7 centimeters and casts a shadow. As you can see here, like this is fairly intuitive. You're already using lots of the terms like location, like number, color, shape, texture, and size. We're gonna talk about configuration later. So this is the first part. And the second part, we just want to replace the term object with more like fancy dermatology terms, which are primary and secondary lesions. So before going into the details of secondary, like primary lesions, it's important to know about like the basic skin anatomy, because one of the key features of dermatology is correlation of like pathology and clinical dermatology. So it's important to know what's happening actually under the skin, okay? So the first one, you want to know about like 3 things, which is epidermis. Epidermis is basically cells produce pigment and protect like immune systems, and then that's epidermis. And then in terms of dermis, the nerves, oil gland, sweat gland, hair follicles within the dermis. And the last one is more deeper. It's called subcutaneous tissue, which is basically fat. When you come to like primary lesions, when I was a medical student, like those terms are very hard to like memorize. Some of them all start with like a P's, and then like some of them are more like less intuitive. So we want to start with 2 most intuitive terms, which is patch and plaque, because those happen in daily lives. When you think about like patch, it's something flat, right? You cannot feel like the patch if it's put on the skin, as you can see the picture. And then we come to plaque, which is something like stuck on the wall, and then it's usually raised, and then it is usually palpable. And then for both patch and plaque, it's more than 1 centimeters. And then this is more kind of like picture, like more kind of like pathology picture, and then like clinical pictures, as you can see on the like right side. And then most of the patch is a process happening epidermis. As you can see, this is epidermis, and then minimal involvement of the dermis. That's why the lesion is flat. As you can see here, if you run your hands over the lesion, it's going to be flat. You're not going to feel the rash. And then for plaque, it's a process in epidermis, plus minus, and dermis. You can see here some process going on in the dermis. That's why the patient will have more like a raised lesion and then have more kind of like palpable lesions. However, when it comes to like smaller lesions, we have like papules and then macules. As you can see, the size is a lot smaller here, and then the size is smaller here. And then we talk about individual lesions, not like the whole picture. And the next one is nodules. And then every time you think of nodules, you want to kind of like ask yourself, what's the relationship between the height and then the width? If the height is bigger than the width, giving like the protruding sensation, and then that's more suggestive of nodules. And then nodules is caused by like even deeper process in, for example, more like mid to deep dermis, like here, can give us a protruding sensation, push all the tissues outwards. And the examples here in our darker skin individual, you can see this is kind of like a lesion is kind of like protruding like to your face. This is more like a nodules. And then the other ones is called like, we use like blisters. So in dermatology, we don't use blisters. We have like more fancy terms. We call like vesicles and bulla. It's basically, that's a clear fluid within the papules. As you can see here, this is, it'll be more obvious if you have like a pen light, and this will be like shiny, clear fluid. If it's less than 1 centimeter, this is the vesicles. If it's more than this is less than 1 centimeter. If it's more than 1 centimeter, this is bulla. And then, oops. And then the next one is pustules. Is instead of having clear fluid, you're having like white fluid, which is suggestive pus. Pus is basically two things made of like white blood cells, mostly like neutrophils, other kind of like leukocytes, and also like the debris like produced from the bacteria, or even like the white blood cells. When you see pustules, don't assume it's infection, because it can both be infections and inflammation. So when you have your differential, you need to have both kind of like differential causes and also like inflammatory causes for pustules. So when you go on electives, then one way to kind of like shine your knowledge is you can combine like primary lesions. For example, if the patient have like both like vesicles and like pustules, you can tell, then you can tell the staff saying like, oh, this patient having like vesicular pustular eruption. Another example is like papular nodules, is based like papules and nodules, or even papular vesicles, because some of them are vesicles, lesions with fluid, and some does not have clear fluid. You can use the term papular vesicular eruption. And then let's go through some examples of secondary lesions. And then like number one is like erosion versus ulceration. And then so the differences between like going back to the picture again, like how deep the lesion was. If it's restricted to the epidermis, and then this is erosion. And if it's going into the dermis, and then this is called ulcers. And then the difference being this will heal without scars, and this will heal with scars. So this is a scarring causing kind of lesion. And then whenever you see erosions, you want to ask yourself, what is before, like what was there before? So it can be either like vesicles there before, the top being peeled off, or this can be like a bullae, could be like things like that. So you want to ask yourself, what is the primary lesions there before? You can ask the patient, or you can look for the rest of the skin to look for like clues. Does the patient have any intact vesicles? Because this can help you generate the differential. And then so this is the difference between erosion and ulcers. And last one that's not commonly discussed in medical school is atrophy. And atrophy is basically on examination, you're gonna see like wrinkling and then shiny appearance. And then that means more of like epidermal atrophy. And then if the atrophy is deeper, if it's in the dermis, you can have significant depression without like the superficial like epidermal change. When you think of epidermal, you think of wrinkling, shiny appearance. When you think of dermis, you will kind of like see like the depression, because the process is a lot deeper. And just give you examples, and you can look at the two pictures, one on the top and then one at the bottom. Just ask yourself, which one do you think is dermal, and then which one do you think is epidermal? So going back up in the picture on the top, you can see the skin looks fairly normal. There's no scales, like no wrinkling. However, you can appreciate a significant depression of the skin. However, for the picture at the bottom, you can appreciate the wrinkling, and then the shiny appearance. For example, here here, pretty shiny, like wrinkling. And then So to conclude, this is more like epidermal process because you can appreciate what's happening like on the superficial layer of the skin, and this is more like dermal atrophy. The reason we want to emphasize is because the differential can be very different if it's dermal atrophy versus epidermal atrophy. And then the last four secondary lesion you want to describe is fissure, cross, scales, and lichenification. Basically, for fissures, it's a linear scars, so, no, sorry, a linear lesions or linear cleft on the skin. It's usually painful, and then around the cleft, there's going to be significant like drying of the skin, thickening of the skin, or even loss of elasticity. You can compare here with here. You can appreciate the differences between those two, between like two areas of the skin. So this is a fissure. And then crust is another important one. It's basically dried serum, blood, or pus on the surface. For example, if the patient has like a pustules, if the patient have a pus, and then when the superficial layer peeled off, when they break, and then those stuff, and then can actually grow on the skin, and then when they dry it up, it can have the crusting appearance. In this case, this is a yellow crust. Basically means it's a serum from the rash that has been dried up. And then this is kind of suggestive kind of like secondary like infection on top of what is happening with the primary lesion. And the next one is scale, because in terms of epidermis, the most superficial layer is actually called stratum corneum, and then that's the layer with lots of dead cells, basically cells without the nuclei. When you have too much of the dead layers, when you have too much stratum corneum, you can have significant scales. For example, here, you can see this patient has lots of scales, and that's because of increased proliferation of the scales, and the skin don't have enough time to have the shedding of the stratum corneum. Or it can be due to delayed desquamation because the skin are not shedding the scales fast enough, and you can have accumulation of the of the scales. So when you think of scales, you want to think of epidermal change. What is happening in the epidermis? The last one is lichenification. Is basically thickening, or the fancy pathology term is called acanthosis of the epidermis. It's basically, you can see this is kind of like relatively normal skin, and then here's the skin with significant lichenification, which means accentuation or marked skin line. You can see this is the natural skin line, and then this is because the patient have been scratching chronically, and then the skin are being responsive to the scratching, and then like a rubbing or irritation, they can have this kind of like irritation or like accentuation of the skin. So those are kind of like the terms you need to use when you describe a rash, the primary and secondary lesions. For example, you're a medical student, when you're on a derm rotation, when you're on elective, if you can use the correct primary and secondary terms or like for the lesions, and the staff will be very impressed. And because your differential will be mostly on the primary and secondary lesions, how they look like. Okay, so we're gonna move on, talk about other component of describing the morphology. So besides the primary, secondary lesions, we also have like location, number, color, shape, texture, and size and configuration. I'm gonna go through some examples and show you why it is important to pay attention to those different factors. So the first one is location. So location can give you a clue to diagnosis, because some primary lesions and then can happen on, so for example, same primary lesions on different part of the bodies can give you different diagnoses. And then the two terms besides location, like location and distribution. So the difference between location distribution can be confusing. Give you examples. For example, location is the anatomic location of the rash. For example, the rash is on the face, the rash is on the elbow. And then example being like Vancouver is this like like the exact location, like the latitude, altitude of Vancouver. However, distribution is more kind of consider the whole body as a whole, and then where the lesion is relative to the body or relative to relative to the whole picture. For example being like Vancouver is in Western Canada, means Canada as a whole, and then Vancouver is on the west side. Some example including acral means on the extremities, and then on the on the hands and feet, and bilateral means like both sides. Disseminated means like the whole body is involved. Follicular basically means the rash is happening around the hair follicles, and the generalized means the whole body is involved. Inframemory basically under the breast, and then photo distributed basically means area that's exposed to the sun, like the face, the hand, and then the dorsal aspect of the hand, and then or like the upper back, the neck. To give you some examples. So the first one, the location. Pay attention to location. The location is on the posterior like arm. This is the location for the first rash. Basically, multiple like papules, and then like skin-colored papules, slightly erythematous. And the second one, the location is basically a fissure. And then the distribution is inframammary, and then basically under the breast, it's kind of like cut linear rash. So the first one is classic location for keratosis pilaris. The colloquial term is called chicken skin. It's autosomal. It's like a autosomal dominant inheritance. If you have it, maybe one like most likely your parents may have it. It's basically bumpy skin over the posterior like arm. And the second one, whenever you have like painful linear cut-like, knife-like like fissure, you want to think of cutaneous Crohn's disease. And a classic location is it's under the breast, and also like in the like growing, or sometimes can happen in the like the vaginal area. So this is location and distribution. And the second one, it's number. Number is important because you want to do the whole examination of the body to ask yourself, is there only one lesion or there are multiple lesions? Because solitary, like one lesion, can be more suggestive of malignancy rather than multiple lesions. And then the next one is color, which is the most important kind of like besides morphology, like one of the most important term can actually give you a clue to what the kind of the rash is, because the color can tell you what kind of cells are actually involved in the eruption. I'll just give you some example here. So the first one, you are seeing something that's like yellow, and when you see yellow, you want to think of like fat cells, right? So this is yellow. And the second one is kind of like, this is more like a green color. And then the last one is kind of like very, very like white, and the lesions on the fingers. So the first one is classic xanthelasma. Is basically like fat deposition, in someone with like, for example, like hypercholesterolemia and hypertriglyceridemia. They can have like those kind of rash over the eyes, for example, either upper eyelid, lower eyelid. And then the second one is classic for Pseudomonas, nail infection. Every time you see anything like purulent discharge with a green color, think of Pseudomonas. And the last one is white. What is white? Calcium is white. And the last one is diagnosis of calcinosis cutis. Is basically calcium depositions over the fingertips. So next time we will see the rash, pay particular attention to the color of the rash. There's way more than just erythematous, okay? And then the next term is called shape. And then it's basically how the rash looks. There are definitely some examples like circular, circumscribed, dome-shaped, gutted, nummular, pedunculated, umbilicated, because the shape of the rash can actually give you a clue what the diagnosis is. Give you some example. The first one is well-demarcated circular rash, circular pigmented like papule. And then the second one is classic umbilicated. This looks like an umbilicus, kind of like central indentation, umbilicated papule. And last one is a pedunculated papules. All those are papules. However, the shape is very different. So the first one is classic congenital melanocytic nevus, which is basically a mole, and then the second one, and then sorry, this one is kind of like the perfect circular shape will make you more pointing towards a benign lesions. Also, the hair growing out of it also suggests more benign lesion. And the second one is a classic appearance for umbilicated molluscum contagiosum, and which is a poxvirus infection. However, it's important to know sometimes they may not have the umbilication, and the other kind of like fungal infection can also mimic molluscum contagiosum, have those kind of umbilicated appearance. And last one is pedunculated, which basically means there's a stalk and there's a bigger lesion coming off the stalk. And this is classic for acrocordon, which is skin tag. And then move on to the next descriptor, which is configuration. And then you want to ask about like how the lesions are arranged relative to each other. And then so that can give you a clue, for example, like how the rash looks. And then if the rash kind of have like a geometric patterns, like they form like a linear line, like among all the rashes, or all the rashes form a particular shape, we call it geometric shape. And then you can think of outside job. It's basically anything outside kind of like causing the rash instead of something like more inflammatory, like more kind of like pathology within the bodies. Again, give some examples. So the first one is kind of like all the rash are like distributed. So all the rash are like distributed kind of like discretely, and then they are kind of like not connecting to each other, most of them. And then the second one is this is called polycyclic, and they have one circles, and second circle like multiple like circles is called polycyclic. And then the last one, the configuration is that we have like multiple tiny like vesicles and papules, and then they are arranged in a linear configuration. So this is the configuration. So the first one is we call mobiliform configuration. Basically looks like measles, and then small like dots, small like papules distributed across the whole body. And the second one is polycyclic, basically means multiple circles. This can make you think of many things, kind of tinea, and then like for example, lupus can present like this. However, the polycyclic nature with the accentuation at the border, and which is actually give it away. This is a tinea infection because the border is where the infection is the most prominent, where the fungal is actually growing. And the last one, anything linear, think of outside job. And then this is poison ivy dermatitis. Basically, the patient was like maybe like hiking, and in Ontario, and then in the bush, and then the poison ivy can cause linear scratch of the skin and cause those kind of vesicular erythematous eruption. And last but not least, it is the texture of the rash. Basically, sometimes you can decide the texture based on inspection. However, sometimes you do need to have like palpate the rash to like give you a more clue of how what is the texture of the rash. And then it can be associated with secondary lesions, for example, like scaly, like scales, and then like crust, for example. And then some of the terms we can use including scaly, wrinkly, we mentioned before, like smooth, pearly. Another, again, give you like 3 examples. So the first one is like very scaly rash. And then this is this very scaly. And then the second one is very pearly. You can see looks like a pearl. And then when you palpate, when you touch it, most likely it's going to be kind of like firm, and then going to be like very smooth when you upon palpation. And the last one is a classic picture of a bus driver. And then one side exposed to the sun, and the other side did not expose to the sun. And over like 40, 50 years, and then you can appreciate the texture of the skin, which is kind of wrinkly, atrophic on the side, but not on the other side. So the first picture is a classic location or even classic texture for like a thick, scaly plaque for psoriasis. And then the second one is a classic appearance of the most common skin cancer, basal cell carcinoma, with a pearly appearance with telangiectasia, which is basically about thin like blood vessels that can like be like a tree, like we usually call it uprising, kind of like a tree appearance, like a branching appearance, like telangiectasia. And the last one is dermatologist, which is a fancy term for photoaging. And then you have patient with chronic exposure to UV radiation. Okay, so we're gonna go through the 4 cases to like further emphasize and then show you how can you present like the rash, how can you present the morphology when you're on elective or when you're doing rotations when you see a rash. So again, going back to like at the beginning of lecture, you want to look at the rash first, and then you're gonna ask more question. Okay, just pay attention, have a look of the rash, and then yourself take a pause of the video, or like take a, or you can if you are like reviewing the recording after, you can pause the video. And then, however, before going into details, I want you to pay attention to the skin type, because skin type can actually change how the rash looks, as I mentioned before. So there are many different classification of the skin type. None of them are actually perfect. The most commonly used skin type classification is called Fitzpatrick skin phototype, and then from skin type 1 to skin type 6. And then one means like pale skin, and then 6 means very dark skin. And then patient with type 1 skin, they usually will get like sunburn, rarely get suntan. And then the patient with skin type 6 can still have sunburn, but it's very, very unlikely. And most of the time they'll get tanning instead of burning. Okay, after you look at the rash, I'm gonna give you the history of the patient. So this is a 32-year-old Caucasian male come to a clinic saying, "Doctor, I have blotches on the skin." And when you ask about question, the 3 T's, and the patient tell you, "I noticed a rash about 2 years ago on the upper back, chest, and arms, and they're completely asymptomatic in terms of trouble, and then worse in the summertime." And then the otherwise patient has some like shoulder injuries, taking some NSAIDs, and then works as salesman, and then only have like 1 long-term sexual partner, and then otherwise pretty non-significant. The reason I included the sexual history is because secondary syphilis can mimic a lot of the rash, especially when the rash is fairly widespread, or the rash is kind of like more scaly. However, syphilis is a good mimicker, and then they can present with any rash. However, when you see like scaly rash, like kind of like a widely distributed rash, I want you to think of secondary syphilis. So for this patient, we're gonna focus on the upper back, and then upon palpation, this is flat, and in terms of size, it's about 0.3 to 0.8 centimeter. I want you to quickly go through this question in your mind, because this is the question you're going to ask yourself next time when you see a rash, when you're on elective, when you see a patient send you a picture. This is kind of question that you ask yourself, kind of like, what is the primary lesion? Any secondary lesions? And where are the lesions located? How are they distributed? And then considering the whole body. And then number of lesions, are they solitary versus multiple? What are the colors? The shape of the lesions? And then texture, maybe on the picture or also on palpation, and what is configuration? Okay, I'm gonna just go straight to the answers. And then, so this is not like unique like way of describing it. This is one of the way describing it. So this is basically a macules, and then none, there's no secondary lesions you can appreciate. And then there's on the upper back in this particular picture. However, the patient does have other sites of involvement on history. And the lesion is fairly symmetric. And then the multiple lesions, and then there's pink to tan color. And in terms of shape, it's round to oval, and then well demarcated. You can draw a line, or you can draw like line around the lesions. And the texture, you may have like some fine scales if you look closely. and there's no particular configuration. The most just discrete, which means that like they're just different ones distributed on the back. So when you present to your staff, or when you like write on the chart, you want to combine everything together. For example, you can say something like, Dr. So-and-so, I saw this patient. This is the male with the skin type 2 to 3. And then symmetrically on the upper back, symmetrically on the upper chest, back, flexural surface of the arms. There are multiple pink to tan colored, round to oval, and well demarcated macules. They're mostly discrete with superficial fine scales. If you can describe this during your elective, during rotation, or when you see a patient in the future, and then this can actually tell the person listening a lot of information about the rash. They can immediately generate a differential based on your description. And this should be your ultimate goal, kind of like if you want to really want to master morphology, this should be like the objective. So go back to the case again. And then because of the fine scales, you decided to scrape some of the scales, and then you perform the potassium hydroxide examination. Basically, you scrape the lesions and you put some potassium hydroxide. And under the microscope, you see the classic spaghetti and meatball appearance. So this is the meatball, and this is the spaghetti, okay? So this is classic for Malassezia, like different kind of species, like for example, Malassezia fervor, and this is a diagnosis of tinea versicolor, which is a very common benign superficial fungal infection from the skin from different kinds of like Malassezia, including like Malassezia fervor. And then you often present with macules, sometimes can be papules if the scales become like thicker. Then classic location, chest, upper chest, back, and then sometimes on the arms. And then patient will be mostly asymptomatic. And then it's usually worse with heat and humidity. So that's why patients say like when sweat, the rash become worse. When in the summertime, every summer I have this rash. Just give you some picture of the patient with skin of color, and then sometimes they can present in patient skin color with more like a hypopigmented papules or like macules. However, the distributions will be the same. The shape will be the same, and then the location will be the same. And let's just give you some clue like this how the rash can look in patient with skin of color. Okay, we're gonna do another practice on another case. So look at the rash again. This time, no history. However, I want you to think in your own mind, like what is the primary lesions, what is secondary lesions, and the location, distribution, number of lesions, color, shape, texture, and the configuration. I want you to put particular attention on the color of the rash, because color can look fairly different in patient with skin of color, especially patient with Fitzpatrick skin type 5 to 6. The color can change quite a bit. Okay, so after you kind of like have your own thoughts for the answer to the question, and this is my observation. Basically, you can see they are very tiny vesicles, and then also a huge, more than 1 centimeter, like bulli. So this is like vesicular bular eruption. And then no secondary lesions because they're all very like smooth, no scales, no lignification, like no fissures, anything like that. And then in terms of distribution, it's on the right upper back. And then in terms of like and then it's also unilateral. It's only on one side of the back, not on both sides. And then there are multiple lesions, like maybe even 50s, like to like 80s. And then the color, that's the thing I want to emphasize. This is more like violaceous instead of red, because in patient skin of color, and then the typical erythema can present with like more like a violaceous hue instead of like the classic erythema in patient with pale skin. And then shape, here's a more like a round to oval shaped. And then texture is shiny, and configuration is grouped because everything is coming together. They're not involved here. It's more kind of group over the upper back. And then is more importantly, it's dermatomal, which means it's follow the dermatome. And then just to summarize, and then you can present like this is a male with a skin type 5 to 6 on the location right upper back, the multiple clear round to oval shaped vesicles and bulla on the red to violaceous background, and then they look shiny and grouped and then following a dermatomal configuration. So if you're able to describe this to someone, the person will immediately think of this as herpes zoster shingles, okay? So this again emphasize it's fairly important to combine all the questions and then put them together. Then that's how you can generate the differential and finally reach the diagnosis at the end. Okay, move on to the next case. And then we're gonna do more like a kind of like a more, you guys should be more familiar with the approach now. We're gonna do more kind of like quicker cases. So in this case, in your own mind, describe the rash, use like all different kinds of questions I asked before, just to orient yourself. So this is the hand, like upper here, and this is the wrist. This is like the dorsal surface, and then this is the hand going down. This is the arm going down, right? I want you to pay attention to location, like where the rash is, and then pay attention to the color, pay attention to the shape, and pay attention to the size, like of the rash. Okay, hopefully you're able to appreciate there's kind of like a square, kind of like an angular, like linear appearance. It's fairly localized, and it's erythematous over the wrist. This should make you think of some kind of like outside job, right? And then, so this is actually allergic contact dermatitis to nickel from the watch. And then ACD is basically a delayed type hypersensitivity, which means the rash will come 24 to 48 hours after the onset of the rash. And then basically allergens, in this case nickel, can activate antigen-specific T cells and cause those inflammatory response, which present with erythematous rash. And then on the history, it's particularly important because there's no way you can differentiate kind of like what a trigger is. You want to ask them particular kind of like exposure, and then in this case, it's a watch. You want to ask about kind of like any contact, sometimes jewelry. If the patient have jewelry of the wrist, can cause jewelries. If they put on any kind of like adhesives, any like stickers over there, you want to ask them is there any contact with any adhesives you put on. Basically, the bottom line is you want to ask about exposure, and then the patient will complain of like intense itchy. And then in terms of timeline, as I mentioned before, it's usually 24 to 48 hours after, and then it's usually fairly localized, and then typically it's no spreading of the rash. And then, so the importance of making the diagnosis is because once you know this is a nickel allergy after patch testing, and then you want to do counseling of the patient, because patient may avoid the watch down the road. However, they may have exposure to other nickel-containing objects, for example, cheap jewelries, doorknobs, keys, paper clips, and then old cell phones. You want to tell the patient to kind of like minimize exposure to those kind of rash because they can potentially exacerbate or cause allergic contact dermatitis because nickel is the most common allergens, and then for allergic contact dermatitis. Okay, so after knowing ACD, I want you to kind of like look at those three rash and then kind of like ask yourself, what could be the potential triggers? So the first patient, we can see again, erythematous, red, inflamed, and then clear border over here, clear border over here. And the second patient, and then what kind of like brown, like a little bit of like brown, violaceous, dark appearance. It's probably more chronic. And however, you can still appreciate a sharp demarcation, like a rectangular. And then the last patient is a sharp demarcation again over the normal skin, and then the skin with the pathology, which is again red, angry, with a sharp demarcation. So the first patient is a patient have allergy to her face mask, some of the component in the face mask. And you can see patient applying like a face mask over top of the face. And then maybe like 1 day after, 2 days after, patient was complaining of this rash. And then the second one is more like a chronic picture. It's basically patient have like allergies to like rubbers, like for example, like there are different components in the rubbers, for example, diagrams, and then a different component people can allergic to in the underwear. This is perfect location for like the wrist of the underwear. And then the last one is the socks, right? This is the perfectly shape of the socks. This allergic contact dermatitis to like nylon in the socks. Okay, this is getting close to our lecture. I want to finish with a fun case to demonstrate dermatology can be very fun, and you can kind of like be a detective when you're seeing rash, because many of the time the rash can indeed look the same. However, as a dermatologist, you'll be the one kind of look at the rash, ask questions to figure out what the patient has, and then help them with the puzzle. So for this particular this particular case is a 30-year-old female come to a clinic with a 2-day history of rash. Basically, it's a new rash. I want you to pay attention to the morphology. Number one, the color is more kind of like a brown, dark, pigmented. And then the striking thing is the shape, which is very, very striking. It's almost kind of like linear, wavy shape. This will make you think of outside job. And then in terms of location, this is on the arms. Again, you want to think of like sun-exposed area. And then the clue for you guys is this patient had a cup of Corona beers at a beach. And then you may not know the diagnosis. And then if you do, this should be like the history and morphology should make you think of one particular diagnosis, which is Lyme plus sun. And then the diagnosis is actually phytophotodermatitis. And then phyto means plant, and then photo means sunlight, and dermatitis means skin inflammation. And then it's basically a substance called furocoumarin in some of the common plants, most commonly, for example, like limes. But then this substance under the UV light can actually interact with the UV light and then become a phototoxic substance that can cause irritation to the skin. So this patient basically was drinking Corona beer in the beach, and then the beer actually was dripping down like the wrist and then the hand. And then after sun exposure, 2 days after, and then the furocoumarin can actually cause irritation to the skin. Initially more erythema, and then later on can cause more like a brown or like hyperpigmentation lesion. So this is the case of phytophotodermatitis. And then this one is a patient was making like ceviche. Of course, ceviche has Lyme in the sun. And then 2 days after, he was having this brown pigmented lesions. Like no one can figure out what's happening. Like he saw multiple physicians, or his family physicians. And then, however, based on the morphology, you can probably pretty sure you'll be able to kind of like figure out this is something outside job on the sun-exposed area. And then by having that morphology, you'll be able to ask the patient, did you have any Lyme exposure? And the patient can tell you they are making ceviche, and then you can make the diagnosis of phytophotodermatitis. And then the last case is a patient with drinking margarita in the sun. You can see like this is a hyperpigmented brown macules and patches, and over the chin and over the cheek. Basically, this patient was drinking margarita in the sun, and then the Lyme component or the fumocoumarin was actually contact with the skin, and under the UV light, they can cause kind of like burning, erythema, and then ultimate pigmentation to the skin. Okay, so this concludes the last case, and also concludes our presentation. So if you guys have any kind of questions, and then please feel free to message me on social media, and I'll be happy to answer any kind of questions you have about like dermatology in general, or any particular question about the presentation.